Good evening, everybody. It's 7 o'clock and let's get going on the right dose. Welcome, everybody, to OPA's live education session series. My name is Ruth Ackerman, and hopefully this thing will work. There we go. And I'm the Director of Professional Development at the Ontario Pharmacists Association. I'll be moderating this evening and talking about a few things as well. Before we get started too far, I just want to make a big thank you to Johnson & Johnson, Mylene and Adriana. They've been absolutely awesome. Took my crazy idea and ran with it. So I'm really, really happy for their support for tonight. So let's go through the agenda for this evening. First, I'm going to start about talking about implementing a new service in your store and why you should do it and what kind of considerations you should have if you're providing a new service in your store. Then we're going to do a bit of an audience check to see where you guys are in smoking cessation counseling in your practices. And then, of course, once we do that, Jane will convince you that smoking cessation is the best service to provide in your store. Then we'll again test your knowledge and your understanding of what barriers both you and your patients will experience when it comes to smoking cessation counseling and smoking cessation itself. And then Jane will smash all those barriers for you. Then we'll go to a pharmacotherapy lesson so that we all feel comfortable with the pharmacotherapy of nicotine replacement therapy and other drugs that you can use in order to help your patients. At the end, we'll conclude with questions and answers. So I want to introduce Jane. I'm so happy that she's here tonight. She's our expert. She's a practicing primary care pharmacist, and she works at the North Durham Family Health Team and in Port Perry, and she's an adjunct clinical assistant professor at the University of Waterloo and a president of Pharmacists for Smoke-Free Canada, which is a group of pharmacist champions that champion pharmacists providing smoking cessation counseling to their patients, and also a founding member of CEASE, which is Central East Association for Smoking Elimination. And its mandate is to bring together a wide variety of healthcare advocates to share best practices. Its members include physiotherapists, physicians, dentists, pharmacists, nurses, mental health therapists, and representatives from healthcare organizations and industry. She's also, and as I said, she's the president of Pharmacists for Smoke-Free Canada. She'll talk a little bit about that later on. And Jane has received an award for the Heather Crow Smoke-Free Ontario Award from the Ontario Ministry of Health in 2016. So she certainly is an expert. Welcome, Jane.
Thank you, Ruth. I'm happy to be here.
So let's just talk about why implementing services in your store is so important. It's one of these things that's sort of very close to my heart. So as we are aware, revenues from dispensing medications are falling every year. So for simplicity's sake, if we used to receive $10 every time we were dispensed a medication, and we're only getting $5 now we have to dispense twice as many prescriptions in order to maintain our revenue stream. And that's why we're so busy right now, because that's exactly what's happening. But if you add services to the mix, then you add more revenue to your profit margin, and you'll be able to either hire more staff or at least ease things up for you as you're not as busy. So always been the right thing to do, and we will become a lot more evident as time goes on how important services are for profitability of dispensaries. Now, COVID, I hate to talk about COVID, but COVID has actually changed a lot of things for us, brought some great things. And number one is put pharmacists first and foremost as healthcare professionals in the eyes of their patients. And I think that don't let go of that. We know that demand for healthcare was rising before COVID, and it's going to continue to rise. And COVID has cramped a few things within the system with access to care And we see doctor's offices that are closed or very short hours. We see long lineups for emergency care and long lineups for even to get a COVID test. So we can see that there's a lot of need for healthcare services, and let's step up to the plate. So if you're starting to plan for a service in your store, there's a number of things you need to think about. What will it look like? Is it going to be this big or that big? Is it a 5-minute counseling session? Is it a 20-minute counseling session? Who is it that will deliver it? Is it going to be the pharmacist, all the pharmacists, just some of the pharmacists? When will the service be available? So is it on demand? Is it by appointment only? And where are you going to deliver the service? It depends a lot on what kind of service it is. You might want to do everything on a clinic day, and you may want to do things in the patient counseling area because you're going to be there for 15 minutes. So you close the door, or you may want to be able to do it by phone. And how will I make it happen in my store? What's the plan? How we bring everybody in? Don't do it alone, and build your support system. Pharmacy assistants are one of the #1 people who can be your support system. And Jane will talk a little bit about the role of the pharmacy assistants in finding patients that are eligible and asking them about their tobacco status. Talk to the owner of the store. If you're the owner, figure out, is it just going to be you? How are you going to reward your pharmacist to do this? How are you going to get them trained? Don't forget, your customers are a really good support to give you a happy customer can give you referrals. And never forget your front shop staff, because they're the ones that are talking to patients as well, the customers in your store, and they can help refer people as well. Other considerations, especially now, is use technology. Use technology to do appointment-based. There's lots of apps out there. There's lots of things that you can tap into to help you do this. There's lots of ways to do this more easily, to set things up so your documentation is easier. Start slow, then build as you gain confidence. Start with your easy patients. If you're going to do a diabetes program, start with the patients that you've known for a while, you're comfortable with, you have conversations with every time they come in, and use them to help you hone down the service that you're going to provide. And last but not least, always make it tangible for your customer. Services are hard because you buy a pair of shoes, you have a pair of shoes to look at. Services are hard because you don't really see sometimes the value of that, but you have to make sure that it is tangible, that they have your undivided attention, and that they see or take home something when they leave. Very important. Just got to give a plug to OPA's professional development programs here. I picked out 4 that are really important to, if you're thinking about services. Paid consultations tells you all the places where you can get paid and how to do those things. Digital disruption and impending change, lots of ideas about what's happening and why it's happening, and the importance of being an advocate for your patients. Managing your pharmacy module on there that's very good. It talks just about patient care services. And of course, the implementing smoking cessation. And we'll be talking about that a little later on. Okay, so now we are at poll time. And I have to go find the polls. Here we go. So let's go with the first one, just to see where you guys are at. Which of the following best describes your current activity on smoking cessation? Go. We've got a few people starting to click in. There we go. I think we're going to be all over the map. We've got almost 50% of you have voted. I'm going to give you a little bit more time, another 12 seconds. Really slowing down now, so. Okay, so what happened here? So let's share the results. So most of you, 53%, are saying, well, I might say something to a patient occasionally as part of counseling. 10% of you say nothing. 21% if they bring it up, if the patient brings it up or they ask about an NRT purchase. 9% provide the counseling and charge ODB, yay. 7% provide smoking cessation services and charge both ODB cash and third parties, yay. So that's pretty exciting. So now we're going to get into, get out of here, and we'll go on, and it's interesting to see where everybody is on this. Again, waiting for, okay. So why smoking cessation as a service? Why, Jane?
Well, it is the most important preventative healthcare intervention that a healthcare provider can do. It is the #1 cause of preventable death and disease in Canada. So 37,000 Canadians die every year from smoking-related diseases, or 100 per day. And 14% of Canadians smoke tobacco age 15 and older, although we do have special populations that are higher percent. So in my clinic, for instance, in North Durham, we're close to a reserve. So we did a poll of our patients, and we have 22.5% of our patients smoke. Patients that have low socioeconomic status, less education, laborers, LGBTQ2, mental illness, and disabled. It's very challenging. All of those are very challenging. So they have a higher percentage of those populations that smoke. And we have to remember that it's a chronic relapsing disease. It's an addiction rather than a lifestyle choice. And why should we get involved? Well, 70% of smokers want to quit, and only 3 to 5% are successful on their own. But we can increase that to 30% success rate if we provide medications and counselings. And it is a journey, so it'll take 1 to 20 quit attempts before the patient becomes smoke-free. An average 6 to 7 quit attempts, but every quit attempt, they learn something, so they get closer and closer to becoming smoke-free for life. So they really need our support along the way. And another reason is the Ontario College of Pharmacists, although our code of ethics used to say do no harm, it currently says that we must help people improve their health. So we don't offer smoking cessation to patients, then we're really not following our code of ethics, because we know it's one of the most important interventions in healthcare. It is a risk factor for practically every chronic disease that there is.
Oh, look at that, another poll. Okay, well, we're going to go on to the next one. Okay. So what do you think is the most important barrier to you in providing smoking cessation counseling? So again, what do you think is the most important barrier to you in providing smoking cessation counseling? We got about 2/3 of you voted already. Very good. Quick on the buttons. That's great. Okay, I think everybody stopped. I'm going to end it. And then let's look at what happened. So, of course, the #1 is time. Of course, we knew that was going to happen. You guys are very busy. But it's very interesting to see that patients not interested at 32%. That's higher than I would have thought. I wouldn't thought that was #2. And then being not comfortable, and your boss doesn't support it and might lose the customer. Like, none of your damn business, right? Okay, so let's go on and start talking about some other things. So what your barriers and what solutions. So here, we knew it was not enough time for smoking cessation counseling. Jane, kill it.
Okay, so you do actually have enough time, and I've made a career out of it actually. And but how I started was I started with just brief interventions. So there's something called the 3 A's, which is ask, advise, and act. It makes it very simple to think of it this way. And several organizations have adopted this strategy, the Ottawa Model of Smoking Cessation, and PACT, which is in Saskatchewan, is the Partnership to Assist with Cessation of Tobacco. So brief intervention, with the next slide, yeah, perfect, is so you're going to ask, you're going to document on the patient file or their profile, and you're going to advise them, and just by saying, this is the most important thing that you can do for your health, and I would advise that you quit smoking. And ACT can be as simple as handing them a pamphlet to Smokers Helpline if you don't offer the service in your pharmacy. So that's the way I started. I just started very small and very quick. And you could see that that takes maybe 15 seconds to do that. It's really, once you get used to it, it's very fast. And documenting on the file is similar to whether you would document their drug allergies or whether they want the prescription picked up. And so if you ask tobacco status, that's just another part of your documentation that I feel should be standard of care. And
it can help, right, Jane?
Pardon me?
Your assistant can help you with that, correct?
Of course they can help you. Yes, you're a team. And in fact, that's where my techs actually and assistants became very supportive of me because they saw how much I could help people. So they actually promoted my program that I was providing, which was really their program too, because I made them feel part of it. And so yes, you're all a team. And even if you just do that, if you just ask, advise, and act, you actually increase the chance that someone will quit smoking, because some people go to places and they're never asked whether they smoke or not. So asking makes a big difference. And if you go, when you get comfortable with that, if you go up into moderate intervention, this is where you want to be reimbursed for your time with your patients. So it's going to be 15 to 30 minutes, 5 to 10 minute follow-up calls. And there are programs out there that do a reimburse. In Ontario, we have the Ontario Drug Benefit Plan, Saskatchewan PACT program, Alberta SMMA, and there's third-party plans like Green Shield. And I also provided a cash service. So I built up my confidence and I built up my program until I was being reimbursed for my counseling and had a cash program as well.
So here's another couple of barriers. While I don't feel like I have enough knowledge, I don't think I understand enough about NRT therapy, how to prescribe the drugs, when to prescribe, what's maybe the doses, but not necessarily when the right patient. And then maybe the manager doesn't know how to implement it.
So through the Ontario Pharmacists Association, we have developed a robust program that is about implementing smoking cessation services in the pharmacy. So you can learn to optimize your revenue and develop better sales and marketing strategies for this service. And the courses, there are, let's see, 4 modules. The first one all about the pharmacotherapy. The second one is motivational interviewing and quit planning. Module 3 is implementing the service. Module 4 is the actual prescribing. And so this program meets the criteria that the Ontario Drug Benefit and Green Shield set out as the criteria for a program that would meet the standards to allow you to bill ODB and Green Shield for your counseling service. So I would strongly recommend, if you didn't feel comfortable, it's easy to get this education online.
So a lot of the owners feel that there's not enough reimbursement to be able to offer smoking cessation programs. Let's talk about reimbursement, Jane.
Okay, well, I have to say that of the patients that I've helped quit smoking, it is as if you have saved their life. So they're very indebted to you. They become very loyal to you. And so I've had them transfer all their prescriptions into my pharmacy if they weren't already a patient. And you have to think of it this way, as each patient is worth $50,000 to you and your business. So the patient can easily buy $100 per month medication. Times that by 12, that's $1,200. Times that by 2 for miscellaneous products bought when they're in the store. And then for over a 10-year period, that's $24,000. And if they bring in one person because they're so impressed with you and your services, that's $48,000. So really, you're thinking about 50,000. You have to think about that in a way of, what does this bring me down the line? If I'm investing into this service, this is the kind of thing that you have the potential of getting in return. Now, the OPA fee guide is really helpful in giving us guidance. If we provide a cash service, how much should we charge? And the counseling is separate from the medication. So when we create our pamphlets, it's important to put, the smoking cessation program is this much money, but then with an asterisk at the bottom that says medications may be included or may be extra, depending on your coverage. And so for counseling, OPA recommends $180 for 4 visits of 15 minutes each. Doesn't include medications, as I said, and you can access this if you're a member on the OPA Today site.
There you go.
Okay, and so just to give you an idea of ODB, this is available. You can just Google ODB Smoking Cessation Program, Pharmacist Smoking Cessation Program, I should say, and all the information pops up on the reimbursement and the training. All of that is all in one place. And so you do actually get reimbursed $125 per patient per year. So you get 40 for initial assessment, 45 for 3 primary follow-ups, and $40 for secondary follow-ups. And keep in mind that they can be virtual, and you can text. You can telephone. I find that I like to have an initials in person and then do telephone follow-ups. But lately with the family health team, I'm doing all virtual, so even initials. And so Green Shield has exactly the same program for reimbursement. They're different pins, but it reimburses very similar to the ODB, the Ontario Drug Benefit Program. And that Green Shield reimbursement depends on the employers, whether or not they have offered the smoking cessation program to their employees. And you get to know your third-party payers and what they'll provide.
Okay, poll time again. All right. So now we want to talk to you about what you think your patients, what challenges do your patients have to quit smoking? Not ready to quit, they're happy, they don't want medication's so darned expensive. Oh, I can't quit. So much stress, I need to smoke. I'll get fat. So they're getting faster on the trigger.
They are.
Took them 45 seconds. Now we have almost, we got 2/3 now.
And I see we have some questions, but I'm thinking we should hold those off to the end.
Yeah, let's hold our questions to the end. Okay, looks like we got everybody. All right. let's see they're just not ready to quit. 41% feel this way, that think that their number one
Patients are
patient
not ready.
challenge is not
Yeah,
not ready.
not ready.
The second one is I have too much stress in my life. Can't quit. Smoking
Mhm.
makes me feel better.
Yeah.
Can't afford the medication. That's an easy one. Influenced by others, and I'll get fat. So let's see what we can do about breaking those barriers down. Sometimes this works and sometimes it doesn't. Okay, so smokers, barriers, and solutions. This is where Jane's years of experience come in, because every smoker, you're going to come in. That question was actually a trick question because, as Jane will tell you, everybody's barrier is the number one barrier. So it's so personalized. Not everybody feels like this is too much stress. Not everybody feels like it's too expensive. So okay, Jane, here's this guy. I'm not ready to quit. I tried and I always fail. What are you going to say to this guy?
So it's important for you as a pharmacist to think about the Prochaska model to see where this fellow might be in the stage of change. So if you look at this, you can see that there's pre-contemplation, contemplation, preparation, action, and maintenance. So I would say that this fellow is in pre-contemplation. But for pharmacists, we can move them through the stages of change. It's not that we're going to, in one interaction, going to get them to quit smoking. You got to break it down. So it's little increment steps. So what I'm going to work on now is moving him from pre-contemplation to contemplation, or contemplation to preparation. So what I do to figure that out sometimes is I want an intervention target. So Ruth, if you just go to maybe the next slide, then I'm looking at, am I dealing with a patient that it doesn't have any knowledge and is very cynical? Am I dealing with a patient who's frustrated? Or am I dealing with a patient who's skeptical? So you can see that area of target is where I'm going to work on. Do I need to work on his conviction, or do I need to work on his confidence? And I think with this fellow, I need to work on his confidence because he's tried. So obviously he wants to quit, but he just hasn't been able to get there. So with that fellow, I'd be thinking about increasing his confidence. And that's what the majority of people are at, actually. And if you offer your service and you offer options, then there's something new now. In the past, we used to have to say, you have to pick a quit date, and it just scares people and they're not ready. And so if you can make it more palpable for them, so you can talk about pre-cessation or practice quitting. So what about if you were to say to this gentleman, you know what, I've got some new ideas on how to quit smoking. In fact, it doesn't even involve picking a quit date. It just involves putting a patch on and see what happens. And I'm here to help you. I can really, a lot of more people are successful if they're working with someone that is knowledgeable in smoking cessation. Another option is just reducing to quit. Do you think maybe you could reduce the number of cigarettes a day? So make it not so scary. And a lot of people will want to try and know that you're non-judgmental, that you're working with them. So that increases their confidence. So there's a lot more approaches that we can use to help move them along from pre-contemplation to contemplation, or contemplation to preparation.
So this lady's not happy because she feels that smoking cessation products are too expensive.
Yes, well, I think in the past, pharmacists used to run away from this question, and they used to say, "Oh my God, it's a financial discussion. I that's too personal. I can't talk to them about that." But you need to talk to them about that because that is a barrier and that is a myth, and that is something that you need to address to bring down that barrier. And so I do have tear-off sheets. I think J&J provides tear-off sheets of the cost of medication versus the cost of smoking. I have a laminated poster in my office as well as to how much money a smoker would spend in a lifetime on cigarettes. And so I get out a calculator and a pen and paper and I say, well, let's just figure this out. How much are you spending on a pack of cigarettes? And then we go over how many, that is in a week they're spending, and then in a month and a year and 10 years. And I think deep down they realize that this is true, but they need to see it in black and white. And the nicotine receptor, the addiction, is trying to find excuses. So it's, oh, you can't afford that. But when you show them they actually can, then that brings that barrier down. And I can even do that with people that are buying contraband at, 200 cigarettes in a bag for $50. I can still show them that they'll save money. And then I also talk about the fact it's a good investment in their health to quit smoking, and what's more important than you and your health. And they usually say, yeah, you're right. So you just need to bring that barrier down.
We have somebody pretty stressed out right now, especially with COVID. Jane, what can you do to help this woman?
Okay, well, actually, we've looked at the World Health Organization and what they say about COVID and smoking. And they suggest that smoking is associated with increased severity of disease and death in hospitalized COVID-19 patients. So it is a good time to quit. We want your lungs to be healthy. We want to do whatever we can to improve your lung health, because COVID is a respiratory virus. So as soon as you quit smoking, within hours, you start to see improvements. So I have a chart also on my wall that shows the improvements over hours, over days, over weeks. And as well, public health is saying the same thing, that comorbidities have an increased risk of adverse COVID-19 related outcomes, and tobacco use is a known risk factor for many of these comorbidities. So things like COPD, diabetes, hypertension, all of these things, smoking is a risk factor for these things. So if we can reduce their risk, then that will be helpful for their outcomes. And yes, a lot of patients, when I'm talking to them, will say, oh, the mental stress right now, it's just COVID, it's just really stressing me out. I don't think I can quit. I don't know how I can do this. If you talk to them that there are supports out there and you explain what some of the supports are, then they just need to talk about it. They need to find some strategies to deal with stress, because stress will always be in their life. And so we talk about stress as being a trigger for smoking, but what can we do instead of smoking? So could we meditate? Could you exercise? Exercise, all of those things release dopamine in the brain. When they smoke, the nicotine goes to the receptor in the brain and releases dopamine, but so does exercise, so does meditation, so does mindfulness. So it's just a matter of helping them to realize that there are other things that they can use for stress that are healthier for them.
Well, this is a good one. I don't want to get fat. I'm just going to be stuffing things in my mouth. Everybody's seen it. People, they quit smoking, they gain 25 pounds.
And it's really important to have a space where patients can say this and feel comfortable saying this to you, and to talk about it and address it head on. For a lot of women, this is important. So don't be afraid to explore it. And individuals gain an average of approximately 11 pounds, but they'll gain more weight if they increase their need their oral fixation. So if they have poutine, if they have all of these fatty chips and whatnot, and they're just trying to satisfy their oral need, then talk about, can you have healthy snacks? Can you reduce your caloric intake? Can you walk for 30 minutes a day? And actually, patients that are quitting smoking are trying to get healthier. So all of these things are actually interesting to them. So you talk about, can you use air pop popcorn? Can you use cut up vegetables? You're still able to do this. Can you use sugar-free gum? So give them a few ideas, and or maybe they might be able to come up with some ideas themselves, as we do through motivational interviewing, of how they can eat healthier. Actually, there is a free dietitian online support as well, if you ever want to tap in, and the Dietitians of Canada will give you tear-off sheets for those as well.
I used to say to some of my customers that gave me this response was that they had to gain an awful lot of weight to have as more of a risk to their health than smoking does. So
Yes, and I do that too, Ruth.
doesn't work
It
with
is.
all of them, but
No, it's certain ones you can, I say to them, you'd have to gain 100 pounds to offset the benefits of quitting smoking, but it just helps to show them how significant it is.
so this guy's in your store and he's pretty cool.
He's
He's
very cool.
45
Oh
and
yeah, he's very
he
cool.
really doesn't care what's going to happen to him when he's 60 because he's 25
Invincible.
and will never die.
He's invincible. Yes.
Invincible.
Yes. So I have done targeted smoking cessation for young people. I was employed by a college to help them with smoking cessation. And I knew that I couldn't use the same techniques that I did with adults because of that reason that you just explained, is they are invincible. So I had to figure out what is important to them, I guess you could say. What is the main thing that's important to them that I could tap into that could make a difference? Well, for young women, it's their looks. And they don't want to get wrinkles. They don't want to have yellow teeth. They don't want to have saggy skin. So Iris is a video that I found that is a young person that's very impactful. I find videos really work well for young people. And within this one with Iris, with every puff she takes, the wrinkles start. And it gets more and more until you actually see her age in front of you to an old woman in about 5 puffs. So it's very impactful. And there are lots of videos out there. And for the men, I found that impotence for young men was really, really important to them. So I found a lot of interesting and fun videos on smoking and impotence because that really sent a message to them, and it tapped in what was important to them. So if they thought that smoking could cause impotence, their eyes would get very wide, and and that really seemed to make a difference. So tap into what you think your patients, what's important to them.
We're going to go into pharmacotherapy. We have some noise in the background, but I don't know why we're getting that noise. So it's not coming from me, but.
Okay, and I don't hear a noise.
Okay, so we hear sort of, it's like a timer going off or something. It's quite strange, but let's
timer.
Yeah, let's dive into smoking cessation. I'm going to put myself on mute because you're going to be talking through this one because you're the expert.
Okay. All right, so who should we ask? Who should we give pharmacotherapy to? Well, it should be all smokers who are making a quit attempt, because the chances of success are significantly enhanced with drug therapy. So you can see that when we add in counseling and drug therapy, that our chance of quitting smoking from 3 to 5%, as you saw before, goes up to 30%. So it can also double to triple to quadruple with just pharmacotherapy over someone that doesn't use smoking cessation pharmacotherapy. And so there's first line, second line, and third line pharmacotherapies. And first line includes nicotine replacement therapy, bupropion, and varenicline. Second line is a combination of first line. And third line, clonidine, cytosine, and nortriptyline. But tonight we're just going to talk about the first line smoking cessation pharmacotherapy because we don't have a lot of time. So Pharmacists for a Smoke-Free Canada developed a Canadian smoking cessation pharmacotherapy algorithm. And I don't know, Ruth, can you maybe move your slide there to that? Yeah, there you go. Okay, so then that is a one-pager and it summarizes everything on it. It's available on our website, on our Pharmacists for a Smoke-Free Canada website. And we'll give you the link to that at the end for you to see. And if I could now go to the next slide, which shows you the meta-analysis of the different first-line pharmacotherapies, you can see that varenicline and the nicotine patch plus a short-acting product basically triple to quadruple the chance over someone trying to quit smoking over cold turkey. So it can significantly improve the chance that they're going to be successful. It is really hard to quit smoking, and this can give them a chance. So along with your counseling, then definitely offer some of these things to your patients. And if you'd like to know how much nicotine are in tobacco products, because this helps you when you're doing NRT, when you're trying to figure out, well, how much NRT should I give to the patient based on how much they're smoking? Well, if they're smoking 25 cigarettes a day, which is common, it's a pack of cigarettes, 20 to 25, there's 1 to 2 milligrams of nicotine per cigarette. So then you're going to need about 20 to 25 to 50 milligrams to offset withdrawal symptoms. And nicotine itself is 99% less harmful than smoking. So if a patient had to go on nicotine replacement therapy for the rest of their life, they'd remove 99% of the harm. So it is something that I find how much they need and how long they need is individual for each patient. You can approximate how much they might need, but you start with that dose and you can go up or down based on their symptoms. So the next slide just shows we've bumped out that Pharmacists for a Smoke-Free Canada algorithm to show you where you can start. If someone, for instance, is smoking 35 cigarettes a day, you can look at this chart. You also use the fact of how many minutes to their first cigarette on waking. So in this case, this patient is, we're recommending a 35 milligram patch, which would be a 21 plus a 14 milligram patch, and some of these short-acting products. And how I teach patients to do this, as I say, well, a short-acting product has 1 to 2 milligrams of nicotine. If you have 10 pieces of gum, that's 10 milligrams of nicotine, and then you have your patches, you add that on, and that gives you a total daily dose. I have had patients, though, just to show you the differences in metabolism and absorption, a patient that smoked a pack a day who needed a 21 milligram patch, but the next patient smoked 25 cigarettes and needed 2 21 milligram patches. So they're rapid metabolizers of nicotine and slow metabolizers of nicotine. So that's why there's variance. But this algorithm gives you an idea of where to start, and you can do that based on the number of cigarettes they're having per day. The next slide just shows you why a combination of a patch plus a short-acting product mimics what the patient is used to having in their bloodstream. So you can see The green line is their nicotine level, and it goes up and down during the day. And the pink area underneath is what the patch is giving them in nicotine. And when the patient wakes up, they don't have any nicotine, they have a cigarette, it's 1 to 2 milligrams, it spikes. Well, if they have the patch on, that's giving them a low consistent dose of nicotine, but you could also give them a short acting product, which would mimic them having a cigarette at that time. But think of it as it's 99% less harmful than smoking. And that's why a combination therapy is statistically more successful in helping patients than single therapy. Although I have had patients who just use single short-acting therapy to quit smoking, and some who have just used the patch to quit smoking. But the majority of people will need both.
So Jane, I wonder if you could help us out here and pause and then just put yourself on mute or fiddle with your microphone for a sec to see if we can
Sure.
get rid of that sound.
Of course.
I can still hear it. Oh no, it's much softer now.
Okay. So how about now? I turned it on.
Yeah, so it got much louder again.
Okay.
Yeah,
Now about that.
yeah, I can still hear it. So it sounds like it's coming from your computer.
Okay. So let's keep it low.
Can you keep it
There.
low?
Yeah.
Yeah,
Is
that's
that
I can
better?
hear you, but I can also hear the sound.
Okay. Is it
Yeah. So just
better?
make sure well, we don't have too much farther to go. So
Okay.
hang in, everybody.
Okay.
Just keep going to the next one then.
Okay. All right, and this is the patches. So there's 21 milligram, 14 milligrams, and 7 milligram, and they come in different brands. The Nicoderm brand is see-through or clear, and the Habitrol brand is skin colored. I find you need to understand the patches. There's advantages and disadvantages of each type. I find the Nicoderm has in their adhesive, they have nicotine in the adhesive, so it actually starts working faster when you put it on. The disadvantage is that it can cause rash in some people. I find it sticks better than the Habitrol. The Habitrol I find is helpful for patients who are very sensitive um, to the patch, so the adhesive isn't in the nicotine isn't in the adhesive, so therefore it causes less rash, but it falls off much easier. So it's just little nuances. Most patients will find one or the other they prefer. And also with gum and lozenges, there are many different flavors. So if your patient doesn't like one, there's others that they can try. So when a patient says, oh, the patch didn't work, or the lozenge, the gum didn't work, well, explore dosing, explore flavors, explore different types of patches. Did it give them a rash? Where did they put it? There's lots of different options that we can do to help them through all of these things. And who better than a pharmacist? And so we do have on our Pharmacists for Smoke-Free Canada website, we do have tips and tricks for helping patients with their challenges with the patch. So for irritation, you can use hydrocortisone cream, apply that on first, give a once a day, a daily non-drowsy antihistamine. You can use a corticosteroid inhaler spray, apply it topically. So a lot of them have COPD. So if they take their Flovent and spray it on, it's a dry powder, and then put the patch on, that can help prevent a rash. And also keep rotating the patches. And for adhesion, apply it to a low sweat area, so different locations on the body. You can use an anticholinergic spray such as Atrovent applied before putting the patch on. And adhesive tape, first aid tape can be used as well. So there's lots of things that pharmacists can give patients ideas. in how they can manage these barriers or challenges.
Now, Jane, we had a question. I think it's a good time to discuss it. This pharmacist has been asked if they can cut the patches. Maybe you could talk a bit about.
Yes. Yes, I recommend that all the time. Of course, the manufacturer doesn't recommend that you do that, but in smoking cessation programs, we do that all the time because it's good for tapering for one purpose. And the other is another reason for cutting them is a box of 21 milligram patches is the same cost as one box of 7 milligram patches. So now you can get more out of 7 patches. So when I worked in a low income area where patches weren't covered, I taught my patients how to do that so that they could get the most bang for their buck, you might say.
Okay, so let's talk about prescribing some medications.
So varenicline. So do you want me to see, as far as this buzz goes, Ruth, do you want me to see if I could make some adjustments to something to see?
Sure.
If you've got a minute, I
Sure.
can try a few things.
Well, let's see if I can, I don't think I can answer these questions. We got some in the chat. Somebody wanted to know whether it was Atrovent inhaler, and yes, that is an Atrovent inhaler. I was very surprised when I saw that on her answers.
So when I turn that off, there's no buzz.
Yeah.
Is there
Still
anything we
going.
can do about it?
Yeah, we can still hear it.
Can I use my phone sound?
You'd have to have Zoom.
Hi, we're just trying some things here. Ruth, does that
Okay.
sound better?
No, we're still hearing it. It just sounds like a fan that's got something in it.
A fan.
Yeah.
Wow. And when I turn my sound off, you don't hear it.
Yeah, it goes away.
Maybe the phone, because as soon as she left, the sound disappeared. What about the connection over there in the window, the volume? My IT person is trying something. I'll keep talking while he's working. How about that?
Okay, somebody said that it's not so bad. So just keep talking.
Okay. Okay. All right. So varenicline is a partial agonist for the alpha 4 beta 2 receptor. And so it provides low to moderate dopamine stimulation. So it tricks the brain into basically thinking it has nicotine. And I have to say for my patients that they all say how significantly it reduces cravings. And of course, it reduces withdrawal symptoms. And there's many, many ways of dosing with varenicline. When we first came out, it was just one way. And that was day 1 to 3. It was 1 tablet of 0.5 milligrams every morning for the first 3 mornings, and then 1 twice a day for the next 4 days. And then week 2, you upped to 1 milligram. But if you just see on the next slide, that there's 3 ways now that the second flexible quit approach is the patient quits smoking between days 8 and 35. So a lot of times I'll say to patients, if you don't quit in the first couple of weeks, don't worry about it. Just keep taking the medication. And sure enough, sooner or later, they'll quit. Or there's the gradual quit approach, which is they reduce by 25% the first month, 50% the second month, and 75% the third month. And then those patients, you'll need another 12 weeks of varenicline. So there's lots of different approaches. in the dosing with varenicline. And clinical pearls, well, dosage reduction in patients with severe renal impairment. It has been approved for use up to 24 weeks. And the side effects to minimize, they're easy to minimize them as long as you mention them to patients to reduce the nausea, take with food and a full glass of water, and to reduce insomnia, take the second dose at supper, not at bedtime. And monitor for any mood changes. And that just, I'm sure people have seen how Champix works. There is the generic now, varenicline. So that is a couple of options for your patients. And bupropion is an NDRI antidepressant, so norepinephrine dopamine reuptake inhibitor. And as we know, it's used in depression. So I find this medication really helpful for patients who are susceptible to depression. And I sometimes use it with Champix as well. So, but on its own, you just take 150 milligrams once a day for 3 days, and then increase it to twice a day, 8 hours apart, and for about 12 weeks, but it can be continued on longer than that to prevent relapse. And the good thing about it, it doesn't cause weight gain or sexual dysfunction, patients like that part. A few common side effects, which can easily be managed. The contraindications, this is much harder to prescribe than Champix. Champix is one of the easiest drugs to prescribe. There's very few contraindications or precautions, but with bupropion, you do have to look at whether they're on any other medications, an MAO inhibitor, if they have a current seizure disorder, if they have bulimia or anorexia nervosa, or if they're undergoing abrupt withdrawal from benzos or alcohol. And so the drugs, many drug interactions with bupropion, and they're ones that lower seizure threshold because bupropion lowers seizure threshold. And that just shows there are many different, just a sidebar, under ODB, Zyban is covered for smoking cessation, but not bupropion. But I use bupropion. We are allowed in Ontario under the regulations to prescribe varenicline or bupropion. And bupropion, I use that in cash paying customers for sure. And so people ask me, what are some relevant factors? How do you decide what to use in patients when they're quitting smoking? And first of all, I say it's shared decision making. It's between you and your patient, not just your decision, but the two of you working together. So you look at the contraindications, you look at previous patient experience, patient preference, and patient characteristics like dexterity. Can they use the spray? The spray is childproof, so I have to teach patients how to use that. And for some patients that have arthritis, it becomes too unmanageable for them. Efficacy, that's the meta-analysis, the addiction level, and the cost and the coverage. All of those things are relevant factors.
So here's this guy that doesn't want to take Champix because his friend went crazy.
Yeah, you get this all the time. I even get it from some physicians and psychiatrists. And I always fax them or give to them or talk to them about the Eagles trial, which showed us it was a robust, randomized, placebo-controlled trial, which showed us that there was no significant increase in neuropsychiatric adverse effects that were attributable to either varenicline or bupropion relative to the patch or placebo. So this gave us the confidence to know that it wasn't these medications that were making people crazy. But in actual fact, quitting smoking is hard. So you will get mood changes, you will get irritability. And so it's important to monitor that. And it's easy to do that with some of these quick scores that we have now, the PHQ-2 or the PHQ-9. You can have that in your pharmacy. I think we have that maybe, Ruth, on the, yes, the PHQ-2. And just a couple of quick questions to monitor when you're doing your follow-up to see what your patient's moods are like, because I have had patients who felt that they were getting depressed. And so I have suggested to the family physician that we consider an antidepressant or consider adding in bupropion as well. So it's easy to manage, and if you use this Eagle study, that will help you navigate that tough question that you'll get from patients.
Okay, so we have a patient here, Blair Smith. We'll just wrap up with a couple of patients.
Okay.
A lot of questions, so we're gonna see what. So Blair, if you guys can read all about Blair, he's 35. He's got some COPD already. He's on a bunch of inhalers. He's in construction. He has to pay cash. He smokes 35 packs cigarettes a day. And his first cigarette, well, he's in construction, so I guess there's opportunity. And first cigarette is 25 minutes after waking. He's tried 3 times, at least he's tried. And he does understand the health consequences, but he doesn't like NRT because it's not working, and he doesn't like the taste, and I'm not taking any meds. What are you gonna do? You guys think about this a little bit, and then
We'll just give you a minute to think about what your response would be, and then I'll share with what I might do in this case.
well, I think you could start to share your thoughts. I think people.
Okay. Well, first of all, I would look at the fact that a few things, actually. I would look at, he started using the gum, but it isn't working, and he doesn't like the taste. So he's smoking 35 cigarettes a day. It's going to be hard for him to meet his nicotine needs with just gum. I would want to ask him if he would be open to adding a patch in for sure. And I would ask him, I would show him, and I do have this in my pharmacy, I have different boxes open where I can have the patient try different things, like different flavors. And they don't mind buying a whole box if they knew they liked the flavor. So there's other options too. There's lozenges. So whereas they might not like the gum, they might like the lozenge. And there's the inhaler and the spray. So I would explore those with him and see if he'd be interested in doing that. At 35 cigarettes a day, you know, that's a very high amount of nicotine. And so I'd be considering that. And also I would revisit Champix or Zyban. Maybe, you know, as soon as if I got a positive response from the patch, I would be, okay, we'll try that. But if I didn't, I'd explore the Champix and Zyban again, why he wasn't interested, what happened, what's he thinking? And it might be some of those barriers that we already discussed.
Yeah, definitely. But then there's always it all is so particular to the patient, right? Everybody's different. So our next patient is Sarah, 45, has seizures. She's unemployed, she's on ODB, 25 cigarettes a day.
Yeah. So yeah. Oh, I just saw, sorry, I see the answers popping up down at the bottom sometimes.
Oh, great. That's fantastic.
Yeah, where they're coming up with ideas, and all of your ideas are good. And you know what? Don't ever think that there's any right way or wrong way. It is just, you know, working with the patient and trying things. It's trial and error, and you know, trying 3 patches, trying this, try that. And that's what I say to patients. It's trial and error. We're just going to work together. And what works for one person doesn't work for another. So with Sarah here, she's interested in bupropion, but I see she's had seizures. So seizures is a contraindication for bupropion. And I have to then talk to her about her patch and gum before not being successful. Why wasn't it successful? What happened? I really find that if you start talking to them about their past quit attempts and what they used and how they used it, you'll find that there was a lot of mistakes they made or changes that they could do that will improve their success. And some people don't think that they can smoke with the patch on. Well, you have to dispel that myth, because what they would do is take the patch off every time they had a cigarette, and that's negating everything, because the myth is that if they have the cigarette with the patch on, they're going to have a heart attack. And you've got to blow that myth out of the water. You need a minimum of 500 milligrams of nicotine to cause a heart attack. So I'd have to put 20 of the highest dose patches on a patient to cause a heart attack. And then having a cigarette with 1 or 2 milligrams of nicotine isn't going to tip them over the edge. They had a heart attack because of their years of smoking. So, that's why you want to talk with patients and explore their different previous quit attempts and see if you can find where you can help them.
Exactly. So that's the algorithm that we'll send to you when we send, and then just our final thoughts about how powerful a preventive intervention smoking cessation is, and that you can do for your patients.
It is, and it's actually one of the most cost-effective interventions as well. So not only is it the most powerful, but it's the most cost-effective if you're trying to advocate with any third-party payers in your area, it's a very cost-effective intervention. And public health has all the stats on this, and they'd be happy to help you if you're advocating.
So here's your opportunity for the bit of the plug for pharmacists for Smoke Free Canada.
Okay, and just you can go to our website, just Google Pharmacists for a Smoke-Free Canada, and under membership, you can sign up for free membership. We have access to all our algorithms and tips and charts, and also we send out emails occasionally to update you with anything involving pharmacists smoking cessation. Pharmacists can be the leaders in smoking cessation. We're the most accessible. We have more touch points with patients than any other healthcare provider, and we're the most knowledgeable as far as medications go. So we can be the leaders in this, and that's what we're trying to do through Pharmacists through a Smoke Free Canada. We want to network with each other and support each other in providing this service for patients.
That's great, and really appreciated all your insights. So in our an invite, we talked about giving away gifts, and it is that time of year, and
Yeah.
I'm not sure, that we have given a couple of things that you'll get post this webinar, but I just wanted to let everybody know that as of today, 50% off the Implementing Smoking Cessation course at OPA. Just go to opatoday.com, search for smoking, and it's right there. If you're a member, it's $50, and it's huge value. You saw the size of it, so just wanted you guys to know, but it's only going to be on until December 25th, and then it'll be over. We'll be packing it up. So thank you again, Johnson & Johnson. Before we get into some questions, my goodness, there's so many. Okay.
Okay.
So
Shoot,
many.
you tell me them, Ruth.
They lots of people with lots of questions. So let's see. A few on the combination of Champex and Zyban.
Okay. What's the question regarding it?
It just says, do you find it helpful?
Yes, I don't use it in a high percentage of patients, but I would say maybe 10% of patients I use it. I do find it helpful if I feel that the patient, the Zyban is, as I said, helpful if the patient is at risk for depression. And
yes. We had
Yeah.
another question around about that, about what doses. Is it Champix 1 milligram BID and bupropion 150 milligrams SR BID?
And yes, but I want you to think outside the box on that. It's not one size fits all. That is the normal recommended dose, but half the amount of Champix, that is 0.5 milligrams, is almost as effective as 1 milligram. And I have had patients who I've gone from half of a milligram daily, all the way up to 3 milligrams daily. So it really depends on the patient, and the same with the Zyban. I've had low doses, 100 milligrams a day, up to the 300 milligrams a day. So, work with your patients. It's really about customization and managing symptoms and along with efficacy.
Hey, early in the conversation, you talked about charging patients for your service and that's what you did. Can you just sort of explore that a little bit? So, because it's scary for people to, we're used to charging for
Yeah.
prescription, and it's pretty common, but
Yes.
what are you
Well,
thinking on that?
so when I first started in pharmacy doing smoking cessation, we weren't reimbursed at all. And this was back in, I would say, 2008. And I started doing it, and my my staff around me was very perturbed that I was doing this because I was taking away time from doing prescriptions. But then they saw how the patients really responded to me and how grateful they were. And my manager started to think, well, okay, you are increasing loyalty and it is a valuable service. And we had been working at the time through Cessation Pharmacists for Smoke Free Canada to get reimbursement for counseling. And that came in 2011, and that was through ODB. So I started doing those. And once I started doing those, I got my confidence up in, wow, there's patients that want to do this. I actually had a lady standing at the counter who said, well, I'm not on welfare, I'm not a senior, but I want this service too. Why can't I have it? And I said to myself, she's so right. So then I started doing a cash service, and I started charging the exact same amount as ODB charged, 125. But then I started to get better and better, and my name spread, and then I slowly increased it to, I went to 175, and then I went to or 200, then I went to 250, and then I went to 300. So it spreads, and smokers talk to each other. So, and also healthcare providers talk to each other. So how I got that job in doing the college smoking cessation was a nurse who had heard that I did smoking cessation and had worked in the same clinic, then recommended me for the college because she worked part-time at the college. So that's how I got started.
Okay, fantastic. I think we don't recognize how valuable our work is. And the other thing too is a lot of changes are happening in this space, and there's so much benefit to an employer if an employee quits smoking, and we are part of the regulated healthcare profession.